Hello, my name is Professor Martin Pitt and I work in Applied Healthcare Modelling and Data Science as Director of the Peninsular Collaboration for Health Operational Research and Data Science, which is a small research team based at the Medical School in the University of Exeter. In this brief presentation, I want to tell you about some ongoing collaborative research work that we're doing, which is looking at the use of computer simulation and modelling to address key issues of patient flow between acute, community and social. For those of us that have been involved in this area for many years, it's becoming increasingly apparent that many of the key organisational issues and challenges facing UK health and social care systems are encountered between the services rather than within them. It's especially apparent within the interface between acute, community and social services, where many key challenges remain. Vast amounts of resources and the quality of patient outcomes depend critically on the effective and efficient organisation of this service interface. And it's going to be really important to address the real capacity constraint issues confronting these services currently in the wake of the COVID pandemic. So although these issues are complex, it's a research area which is extremely important and one that we need to address fully. One significant area of research which has a proven track record of supporting decision and policy making within the health and care system is operational research through the use of modelling, analytics, simulation, forecasting and other such tools. To date, it's fair to say the majority of this work has tended to focus on specific treatment pathways or defined services, such as an A&E department organisation. Much less modelling has been focused on exploring the interfaces or handoffs between separate service providers. So pathway and system-wide modelling across different care settings present specific challenges, which has perhaps acted as a deterrent for modellers to date. But this is clearly, from what's said before, an important area that we need to address, and increasingly operational researchers are looking at ways in which they can address these issues. In order to address some of these challenges, the IPACS project, Improving Patient Flow Between Acute and Community and Social Care, was established as one of 5 core projects within the Better Care Partnership Hub based at Bristol. This is a funded research project by the Health Data Research UK, which is ongoing at the moment and comprises 6 researchers based at Bristol, North Somerset and South Gloucester Clinical Commissioning Group, the University of Bath and the University of Exeter. The primary objectives of the IPEX projects, which are listed here, is to use computer simulation and other operational research tools to look at ways in which we can investigate the balance of care, specifically looking at things like bottlenecks, allocation of resources, what difference capacity changes make, and with the aim eventually of developing tools that will be useful in decision support for managers and planners in the health services. Underlying our research is the hypothesis that there's a trade-off between acute and community care, and that there's an optimal point at which the allocation of resources to social care can reduce the costs of acute care such that overall system costs can be minimised. The initial focus of the IPACS project was to look at the discharge to assess pathways in intermediate care provision, looking at the 3 options of P1, P2 and P3 care pathways representing different levels of intensity for the patients leaving the acute hospital. In terms of the value of modelling these pathways, there's a number of questions that could be asked and would be of a great interest to some of the managers who organise these services. And these are listed here, but I mean obviously the key areas in which the modelling can provide insights is by providing a way of visualising the pathway, understanding the interactions between the different services and the impact of changing variables within the system in terms of the outcomes, the costs and other key aspects of care provision. So our initial model allowed us to look at some of these key questions, working closely in collaboration with many of the managers and service providers in order to see how we could use simulation. This schematic represents the basic simple flow of patients through the 3 pathways that we've identified, and was used to investigate some of the key interactions and relations and some of the management questions as outlined in the previous slide. So although it's not possible within the scope of this presentation to go into detail about the outputs from the simulation model, it's important to note that many of the outputs have been used and applied for things like business cases in the local area around Bristol. Much of the work that we did initially with our version 1 of the model was concentrated on that Bristol area. But we were looking also at ways in which we can extend the model to use in more generic application for other regions and so on. And this slide shows a range of outputs for different scenarios. So it's a kind of scenario analysis within the context of the COVID pandemic, in which we're looking at the impact of various scenarios and vaccine uptakes on things like the weekly costs, the service occupancy, and the level of delayed transfers of care across the system. For those interested, I put the reference there to a recently published paper which outlines the technical aspects of the modelling that was done to support these output graphs. Another very interesting output from our analysis, based largely on queuing theory, runs counter to the contention that we should try always to reduce delayed transfers of care from acute hospitals to zero, when actually more optimal outputs are obtained when a small level of delayed transfers of care is maintained, in order to avoid overcapacity within the community care sector. If those interested in this analysis, there's a recently published paper with a reference at the bottom of this slide that gives much more of the technical details and some of the important aspects of that analysis. Based on our experience with the version 1 of the simulation model and through feedback from consultations with health and care managers in the various services, we decided to develop a more complex model which allowed for more flexibility and to look at more granularity at some of the key issues involved in managing the service. So this is a diagram which represents the structure of the version 2 of our simulation model, and you can see from this that many more aspects of the care pathway are incorporated within this model, which allows us to look in much more detail at some of the key issues to do with queuing, for example, or to do with the parallel administration of care between the NHS and community services and so on. So this is a structure that allows us to perform many more analyses and address some of the more critical questions, more detailed questions indeed, to do with delivery of care. So within the current phase of the IPACS work, we're beginning to look at a range of different issues which we can do using the revised structure on the version 2 model. These include things like looking at the queuing behaviour of patients, looking at modelling issues around flexibility of resource provision, for example the use of spot purchase for beds for P2 and P3 patients, and whether what's the efficiency involved in that, how important is flexibility within the system. We're also hoping to engage more closely with the patient and public involvement researchers, such that we can get a sense of what the priorities of patients are within the care pathways. After this, we're looking at ways in which we can package these tools so that they can be used more readily and accessibly by members of the health and care professions to address some of the key questions that they have. And we'll want to, in the end, to evaluate and test the usability of these tools and see how they can be applied. On top of that, we're also looking at ways in which we can turn the tools which have largely been focused on the care system within the Bristol, North Somerset and South Gloucester area to other areas of the country where different organisation services may exist, and we're currently liaising with other services within Devon, for example, and Somerset to look at ways in which we might use these tools more generically and eventually develop tools that can be used more generally across the service. So in conclusion, it's important to stress that this is ongoing research work and we're still discovering much as we travel through this research programme. Clearly what we're doing, what we're modelling is a key area of healthcare and badly needs the support of modelling tools and evidence-based outputs in order to inform decisions. I think there's a range of things that we've learned from the research so far. It is difficult. There are key issues to do with data access and matching data. The differences in data quality, for example, between different service organisations is quite stark in many cases. We also need to understand the priorities of the patients. Another key area that I think is critical in this context is the presentation and communication of the modelling outputs, such that they can be understood and woven into the decision-making processes of the institutions responsible for delivering care. There's clearly a great scope and potential for the adoption of such approaches, and I think this project, the IPACS project, begins to demonstrate these potentials, although there's an awful long way to go in terms of turning these models and these tools into really useful applications that can seriously influence and affect the development of services. Having said that, of course, there is evidence already that some of our models have been applied and have been used to important effect within the services, such as supporting business cases and so on for the various community agencies. So thanks for listening to this presentation. I hope you found it interesting, and if you want to learn more about operational research and data science research group at Exeter, there's a web link there. And finally, thank you and a call out to Health Data Research UK, who funded the IPACS work.